In this video, we will discuss spirometry in relation to obstructive and restrictive lung diseases. But before proceeding further, I would request you to recap lung volume and capacities we discussed earlier. The ventilatory disorders are broadly categorized into obstructive lung disease and restrictive lung disease. Now consider this a normal cross-sectional view of the lung. The red ones are the airways in the lung, and the blue area around it is the parenchyma. In obstructive lung diseases, the parenchyma, which is rich in elastic tissue, remains normal, but the airways become narrow due to obstruction. This obstruction can be due to three main reasons. First, it could be due to excessive secretions in the alveoli, for example, as in chronic bronchitis. Secondly, it could be due to destruction of the alveolar walls, as in emphysema. And finally, it could be due to hyperreactivity of alveolar smooth muscles due to chronic inflammation, like in asthma, causing spasmodic contraction of these alveoli. And in chronic obstructive pulmonary diseases, actually it is a combination of chronic bronchitis and emphysema. Now think, if a patient has obstructive lung disease, will that patient have difficulty in inspiration or expiration? The answer is expiration, because during inspiration, the airway will expand normally because the outward traction is present. However, because of the obstruction in the airways, they become more narrow during expiration, so they are unable to throw out all the air. This causes air trapping in the lungs every time the patient breathes out. So over time, due to this air trapping, the lung become larger than normal, or we can say the lungs become hyperinflated. In restrictive lung diseases, it is the other way around. The airways are normal, but the parenchyma is disrupted due to inflammation or fibrosis. The parenchyma becomes more dense, which restricts the expansion of the lungs. So the lungs will become smaller and stiffer than normal. I hope you remember this graph from the previous lecture. Normally, the amount of air inspired and expired at rest is called tidal volume. The maximum amount of air inspired after normal tidal inspiration is inspiratory reserve volume. The maximum amount of air expired after a normal tidal expiration is expiratory reserve volume. And the amount of air left in the lungs after maximal expiration is residual volume. Lung capacities are derived by adding these lung volumes. They provide useful information about the strength of respiratory muscles. Amongst these, vital capacity is the most important measure to interpret spirometry results. It is a sum of inspiratory reserve volume, tidal volume, and expiratory reserve volume. Functional residual capacity is derived by adding expiratory reserve volume and residual volume, and total lung capacity is derived by adding all four lung volumes. Now let's compare the obstructive pattern and restrictive pattern with the normal lung volumes. As we discussed earlier, that in obstructive lung disease, the lungs are more compliant, which means less stiff, and they become bigger than normal. So the total lung capacity increases. The inspiratory reserve volume, however, will be slightly decreased. Although in obstructive lung disease, the patient doesn't have significant problem during inspiration, but due to overexpanded lungs, the patient won't be able to make much effort during inspiration. So inspiratory reserve volume is lower than the normal lung volume in obstruction. The expiratory reserve volume will be significantly reduced in obstruction because of the air trapping in the lungs. This means that the vital capacity will also be reduced then, but the residual volume will be more as compared to the normal, again due to air trapping. On the other hand, in restrictive lung disease, because the lungs are more stiff and small, all the lung volumes and capacities will be reduced. So total lung capacity is reduced, as well as the inspiratory reserve volume, expiratory reserve volume, vital capacity, and residual volume. So in restrictive pattern, everything is reduced. And that's it for now. In the next lecture, I'll explain you how to interpret spirometry results to diagnose obstructive and restrictive lung diseases. Take care. God bless you all.